Today we are reading concise textbook of pediatrics. So the first chapter, pediatric clinical evaluation. History taking. History provides the most vital information in pediatric problem solving. More important information is often obtained from a good history than physical examination and multiple laboratory investigations. History generally is narrated like a story. It describes the child's illness, birth details, growth and development, immunization, and socio-economic and cultural background, providing information to identify problems and offer practical solutions. The history is often obtained from the mother or an other adult accompanying the child. Older children themselves provide essential information, and getting them involved in the process helps to build a good patient physician relationship. Listening and observing are essential skills in obtaining a good history. Facial expressions, tone of voice, and gestures often convey valuable information about underlying issues. All the senses must be on alert to pick up these nonverbal cues. Training one's eyes, ears, and mind are as valuable as training one's hand. So, tips for obtaining a good history: establish warm, friendly atmosphere, maintain privacy, and remove distractions. Provide toys, paper, crayons, books to keep the child engaged. Maintain good eye contact with the parent and child. Allow the parent and the child to do most of the talking. Listen actively, using strategically placed questions to obtain important details. Use simple language. Avoid medical terms. If the parent uses medical terms, ask them to explain what they mean. Encourage the parent to ask questions and clarify what is unclear. Observe carefully for nonverbal cues. Although the history is usually written under the subheadings below, it should be narrated as a story. A good history creates a clear picture of the child and the family in the mind of the listener. Some students are naturally good at storytelling and should use the skill to their advantage. However, it is a skill that can be perfected through regular and conscious practice. Take as many histories as possible and present them to the teachers and colleagues. So, the personal information: name, age, gender, residential address, note the contact telephone number, name and the relationship of the informant to the child. Presenting complaint and duration. The complaint that brought the child to the doctor or hospital and the duration. It should be kept simple and stated in the words of the parent. Do not convert the complaint into medical terms. Next, history of the presenting complaint. It is the most critical part of the history. It describes the complaint, describes in detail the complaint and that brought the child to medical attention and is the basis for clinical diagnosis. Start from when the child was last well and describe symptoms in chronological order. Allowing the parent and the child to tell their story and keeping interruptions to a minimum will help you to obtain a clear picture. Once the parent has finished narrating the event, ask questions to get more details and clarify doubts. This will allow you to form a tentative diagnosis. It is helpful to ask parents whether they have a video clip of the event they describe. For example, seizure or movement. This allows clinician to become an eyewitness of the event and could be invaluable. Use the parents' words as much as possible and avoid using medical terms. To avoid confusion, use only one format for the timing of events. Example 1, 2, 3 days ago or 25th, 24th, Monday, Tuesday or Wednesday. When describing a chronic or episodic disease such as cerebral palsy, bronchial asthma or epilepsy, describe the current complaint. So in chronic conditions, we have to describe the current complaint or the episode in detail and link it with the past illness or episodes. Do not keep this information to present later under the past history, as it is a part of the same illness. So in the history of the presenting complaint itself, we have to tell about the current episode as well as the past episodes. This child has had three similar episodes in the last 2 years, which were milder and did not need hospital admission. He was started on prophylactic steroid inhaler, which the mother stopped after 1 month. Always seek a history of similar problems in contacts or relatives. A quick systemic inquiry should be included at this stage to screen for any other issues that have not come to your notice. Don't spend a lot of time on this, it is only a screening tool. So, in the systemic inquiry, CVS, cardiovascular system, infants, we have to ask about sweating or tiredness during feeding, interrupted feeding. In older children, fatigue during playing, syncope, murmurs heard by a doctor. Respiratory system, cough, wheezing, difficulty in breathing, noisy breathing, snoring, sore throat. Gastrointestinal tract, appetite, toilet trend, bowel habits, consistency, frequency, vomiting, abdominal pain. Genitourinary system, urinary symptoms such as dysuria and frequency, urine, color, smell, froth, vaginal or penile discharge, itching, menstrual history if applicable. And the central nervous system, seizures, febrile or afebrile, abnormal movements, headache, body weakness should be asked. And miscellaneous, fever, skin rashes, joint swelling, ear or nose discharge should be asked. And then comes the past history. Since this relates to a child, start from the birth. The amount of details you need will depend on the presenting complaint and its relationship to events surrounding the birth. Ask the mother to relate the sequence of events from birth to present in chronological order, including details of feeding, growth and development, and any previous illnesses. So, in the past history, we asked about the prenatal period. So, mother's age, previous pregnancies and complications. Is this a planned pregnancy? Antenatal care received, pregnancy complications, exposure to drugs, alcohol, and smoking. At birth, the birth weight, period of gestation, mode of delivery, spontaneous onset or not, duration of labor, birth complications including birth asphyxia, details of resuscitation. In the neonatal period, we should ask breastfed or not, feeding issues and support given, jaundice, phototherapy or exchange transfusion, infections, NICU or SCBU care. When did the mother and child go home? So, about feeding during infancy, duration of exclusive breastfeeding, which should be ideally 6 months, and continuation of breastfeeding, age of introduction of cow's milk formula if applicable, details of complementary feeding, the age when it was started, and the type of food given. In an older child, we should ask about the current diet, type and quantity, frequency of feeding, any feeding issues, food refusal, food fads. It is in the growth and development, this is an essential set of information for any child. But how much details need will depend on the age and the presenting complaint. What it's an infant? When it's an infant, much more details are needed than for a bigger child. Ask for the child health development record. CHDR, or any other document which has records of the child's growth and development. The CHDR used in Sri Lanka is gender specific and contains details from birth to 19 years of age. So here are the pictures of CHDR. About the growth, the CHDR contains several growth charts. Birth to 5 years, wait for age chart. From birth to 5 years it contains. Length or height for age chart. That also contains from birth to 5 years. Weight for length or height. That's also from birth to 5 years. Then after 5 years, 5 to 19 years, we have height for age chart, BMI chart. Inspect the growth charts to assess the growth pattern. Ask whether there have been any concerns about growth, and if so, what action has been taken. In school children, additional information may be available from the records of school medical inspection carried out in grades 1, 4 and 7. Then development. A brief developmental history should be taken in all children to decide whether the child is developing normally or not. Check the development pages in the CHDR for previous records. So in infants and school children, was the development monitored routinely? Where was the monitoring done? Any parental concerns about the development? Did anyone else raise concerns about development? Midwife, relatives, or friends? What action was taken on these concerns? In a school child, we ask current school grade, is it age appropriate? What are the best and worst subjects? Any parental concerns about school performance? Any concerns or complaints from teachers? Any interventions? Extracurricular activities. Inspect school books and record cards, they provide a lot of information. If there are concerns, a detailed history with key developmental milestones is mandatory. This is explained in detail in chapter 3. And past illnesses. Any illnesses needing regular medical attention, GP, OPD visits, accidents. Any hospital admissions including ICU admissions, record these by date and age, medication or allergies. And then immunization. What vaccines were given? Where were they administered? Any reactions? Any missed vaccines and reasons for missing these? Inspect the immunization record of the CHDR for confirmation. Then comes the family history. In the family history, some diseases have a genetic basis, and exploring the family history in these conditions is essential. Drawing a family tree is the simplest way to identify the relationship of the affected individuals to the patient. Even when there is no suspicion of an inherited disease, drawing a family tree is a useful exercise as one can record multiple details including age, educational status, occupation, and health status of the family members. So, in the family tree, we start from grandfather and grandmother. Then we write about our child's parents and the parents' siblings, aunt, and parents how they got married, and brother, any siblings the patient is having, likewise. So in this side also, in father's side also, we can draw about the grandparents, any siblings, etc. Then becomes complete. So, if the child is suspected of having a disease with a genetic basis, mark all the affected members in the family tree. The clinician may have to talk to other family members to get more information with consent. Is there consanguinity? If so, what is the exact relationship between the parents? Any genetic diagnosis made? Any interventions? What was the outcome in the affected members? Have they received any genetic counseling? are important factors. Then family interactions. Try to get a feel of the type of family. The clinician may be able to understand the underlying intentions. This information is very valuable when planning the management. Observe the child parent interaction. If both parents are present, observe their interactions. How do they look? Happy, sad, angry? Does the child appear happy, anxious, or sad? Who appears to take decisions of the family? Decide whether it is a well balanced or dysfunctional family. Finally, the social history. Social history. The social history provides you with information about the child's background. This information is vital in formulating a plan of management. Parents' occupation, parents' educational status. Is the father or mother overseas or absent from home for long periods? Housing conditions, space, ventilation, overcrowding, sanitary facilities, support systems, grandparents and other relatives or neighbors or friends, financial status of the family, income, allowances, loans and debts, marital issues, disharmony, separation, divorce, and the life events such as deaths, chronic illnesses, family moves, psychiatric illnesses, depression, psychotic illnesses, substance abuse, alcohol, tobacco, or drugs. At the end of the history, it is essential to arrive at a tentative diagnosis or a short list of probable diagnoses, differential diagnosis, that can explain the entire clinical picture of the child. It is important to list problems that have already been identified in the child and the family. Formulating a differential diagnosis and a problem list is explained later in this chapter. So, the key points are: allow the mother and the child to do most of the talking. Keep your eyes and ears open to pick up non-verbal cues. Taking a few moments to make the mother and child comfortable is worthwhile. Narrate the history as one would narrate a story. History is the basis of clinical diagnosis. Physical examination, laboratory investigations, and imaging only help to confirm the diagnosis suspected from the history.